Diabetic ketoacidosis management. Number 1. Airway. Ensure patient is maintaining on airway. Sit patient up to prevent acidosis. Number 2. Breathing. Check SpO2 and correct hypoxia with supplementary oxygen. Watch for Kussmaul's breathing, which may be present to compensate for metabolic acidosis. Number 3. Circulation. Vital monitor BP, pulse rate, respiratory rate, temperature, SpO2 for hourly. Maintain 2 large bore intravenous line, that is 20 gauge. Monitor labs, blood sugar level, 1 hourly, ABGs 4 hourly, input output record 1 to 4 hourly, electrolytes 4 hourly. Insulin therapy. Number 1. Injection regular insulin, that is 5 to 10 units IV plus 5 to 10 units subcutaneously stat. Insulin infusion. 16 unit of regular insulin injection with 100 ml 0.9% normal saline is prepared in 100 ml IV chamber. 10 microdrops per minute start if potassium is more than 3.5. Number 3. Not to start IV insulin if potassium level is less than 3.3. Maintain serum potassium between 4 to 5 milliequivalent per liter. Number 4. Continuous IV insulin infusion until the inine gap is normal. Number 5. Once inine gap is normal, then shift the patient to subcutaneous insulin. Fluid replacement therapy. Extracellular fluid loss is replaced by 0.9% normal saline, that is isotonic solution. Intracellular fluid loss is replaced by dextrose 5% or 10%. Fluid of choice is 0.9% normal saline or 0.45% normal saline. First hour, 0.9% normal saline, 1000 to 1500 ml or 1 to 2 liter bolus fluid at 15 to 20 ml per kg per hour. Next 24 to 48 hours, adjust intravenous fluid rate and composition according to CVP, urine output, blood glucose and corrected sodium levels. Then 1 liter of 0.9% normal saline in 2 hours. Then 1 liter of 0.9% normal saline in 4 hours. Then 1 liter of 0.9% normal saline in 6 hours. Then 1 liter of 0.9% normal saline in 8 hours. Change to 5% dextrose once blood glucose is less than 200 to 250 milligram per deciliter. Most hospital ward and ER protocol as follows. Number 1. First 1 to 2 liter 0.9% normal saline is given fast in first hour. Number 2. Then 3 drips of 1 liter 0.9% normal saline is given at the rate of 125 drops per minute. Add 20 ml, that is 20 to 40 milliequivalent of KCl to each liter of 0.9% normal saline once potassium is less than 5.5. Number 3. Then fourth drip of 1 liter 0.9% normal saline plus KCl 20 ml is given at the rate of 88 drops per minute. Number 4. Then fifth drip of 1 liter 0.9% normal saline plus KCl 20 ml is given at the rate of 33 drops per minute. Number 5. Then sixth drip of 1 liter 0.9% normal saline plus KCl 20 ml is given at the rate of 22 drops per minute. If pH is 7 or less than 7 despite adequate IV fluid resuscitation, administer IV injection sodium bicarbonate into 2 vials, that is 50 ml per cc in 500 ml of 0.45% normal saline in over 1 hour. Acidosis usually resolve with fluid and insulin therapy. The use of bicarbonate is usually not necessary. Current study. Sodium bicarbonate should be avoided. Oxford Textbook of Medicine. Start 5% dextrose if random blood sugar value is less than 200 to 250 mg per deciliter at the rate of 125 ml IV per hour. If random blood sugar value is more than 250 mg per deciliter, change dextrose to 0.9% normal saline. Number 4. Disability and exposure. Secondary survey. Consider early HDU and ICU admission. NPO status in patient with high anion gap metabolic acidosis on insulin infusion. Pass nasogastric tube and Foley's catheter. Monitor pupillary reflex and GCS level. Injection calcium gluconate in 100 ml 0.9% normal saline over 15 minutes if indicated SOS. Antibiotics cover injection ceftriaxone 2 gram, rosufen or injection moxifloxacin 400 mg, Moxigat IV OD. PPI injection omeprazole 40 mg IV OD. Give appropriate analgesic if pain and antiemetics if nausea and vomiting. Thank you.